ये off तो नहीं होगा. Hello students, good afternoon and welcome to this session of dermatology. This is our last resort revision for FMGE exam. I would not say this is the last resort. You still have a lot of time. I'm sure your preparations are at its peak and you must have revised all these subjects. This is just to quickly recap. This is a quick recap of the important topics in dermatology. Now, since this is LRR, I will not go into the depth of each topic. I will quickly go through various topics which I think are important for you and the relevant questions that are asked. However, you are free to interact with me, chat with me, tell me if you need any extra info on anything or you want me to discuss any topic. If my time permits and if everything goes well, we can discuss all of that, right? So let's make this session interactive. The more you answer, more I know that okay, you know this and I can skip that and move further to the next topic, right? So very good afternoon. Hope all you had your lunch and now you're all geared up for this dermatology session. I'll try not to make you sleep in this afternoon session. Okay, so is my voice audible now? There's few responses in the chat box which says that there is no sound. I hope I'm audible now, I'm visible now. Perfect. So this session would be based on previous year topics which have been asked. So first of all, I'll be discussing my favorite topic when you get questions which are related to formation of bullas, erosions or blistering disorders. Perfect. So let's get back to the session. Now most very commonly they give you an image like this and the question that is usually framed is a middle-aged female presents with blisters on the body or fluid-filled bulla on the body with oral erosions. So if I have fluid-filled bulla and oral erosions, what is my first DD? What is my first differential that you would think of? Not bullous impetigo, come on. I am telling you there are fluid filled lesions, there are oral erosions. So bullous impetigo is not the right answer because bullous impetigo would not have oral erosions. So non-healing oral erosions with fluid filled bulla and mostly in the exam they will give you flaccid bulla. So if this is there in your examination or in the history, you have to think of Pemphigus vulgaris. So whenever there is a question on bulla formation, so there can be autoimmune blistering disorder in which Pemphigus vulgaris is one of the most commonest one. You have flaccid fluid filled blisters. So flaccid lesions with non-healing oral erosions is a perfect combination to make a diagnosis of Pemphigus vulgaris. Since you had given me few other inputs, I'll be discussing all those options here and so it would be clear by the end why is it not bullous impetigo or why is it not herpes, okay? So these are the two things. Now, if I have something like this, where they tell you that in the seborrheic distribution, which can be upper chest and trunk, you might have bullae, but mostly what you get is crusted erosions. So on seborrheic distribution, there are crust. So Pemphigus foliaceus does not have mucosal involvement because in Pemphigus foliaceus, my target antigen is desmoglein 1. And desmoglein 1 is compensated by desmoglein 3 in the oral mucosa. So when the target is only desmoglein 1, the mucosal involvement is not seen. So remember Pemphigus foliaceus, F for first, F for foliaceus, the target antigen is desmoglein 1. With Pemphigus vulgaris, my target antigen is desmoglein 3. Please remember this. These are two other important questions that is asked. Is it stuck? Okay. Right. So, desmoglein 3 is the target antigen in Pemphigus vulgaris. In Pemphigus foliaceus, it is desmoglein 1. What is the level of split in Pemphigus foliaceus? It is, since there is some lag, so I am going quickly. If you feel there is some problem, you are not able to get me, please write it in the chat box and we can discuss it here. Now, here the bulla are subcorneal. Desmoglein 1 is situated in the upper layers of the epidermis. So, here the bulla are subcorneal, and because they are subcorneal, they are very superficial bulla, so they rupture easily and we see crusted erosions, we hardly see any blisters. Whereas in Pemphigus vulgaris, the bulla is suprabasal. It is above the basal layer, it is in stratum malfigi, which is my basal layer, and stratum spinosum. So, I have suprabasal bulla here, and so the bulla are flaccid. Got it? Great. So, this is how you differentiate between vulgaris and foliaceous clinically. Then lot of times they will give you a histopath image. Now, look at this histopath image. What do you see here? You are seeing a split in the epidermis. This is my whole epidermis. This is the whole epidermis, and you see a split in the epidermis. And where is this split? This is my basal layer, and the split is just above the basal layer. So, a suprabasal split, and suprabasal split is suggestive of Pemphigus vulgaris. So, suprabasal split, Pemphigus vulgaris. What else do you see on histopathology, which is asked in the exam? You also see this appearance. What is this appearance called? We will come to that. I am talking about tombstone appearance. Very good. So, row of tombstone appearance on histopathology is again suggestive of Pemphigus vulgaris. Suprabasal split and row of tombstone appearance. In DIF, you are all correct. What do I see on DIF? I see fish net pattern of immunofluorescence. Easy to identify. The pattern is just like net hair. So, fish net pattern, so row of tombstone appearance, suprabasal split, all this is suggestive of Pemphigus. Now, what is the gold standard test to diagnose Pemphigus group of disorder? It is DIF. So, DIF is my gold standard test. If they ask you, it is not biopsy, it is not Nikolsky, it is DIF. Okay. Now, coming to Nikolsky sign, since someone said Nikolsky sign is positive in Pemphigus group of disorder. What is Nikolsky sign? If you apply a shearing force, the skin splits off and a bulla is formed at that site. So, this is Nikolsky sign, and this is positive in Pemphigus group of disorders. Clear? Sorry, what are you asking? Okay, got it. Now, moving on, this is a quick recap. How do you differentiate between foliaceous and vulgaris? Already told you, desmoglein 1, desmoglein 3, bulla is subcorneal, here the bulla is suprabasal. In Pemphigus foliaceous, bulla ruptures easily, so you just see crusted erosions. In vulgaris, you see flaccid bulla. Oral mucosal involvement will be seen in vulgaris, not in foliaceous. Seborrheic areas are more commonly involved in Pemphigus foliaceous. So, based on these, you can easily differentiate between vulgaris and foliaceous. Now moving to the next set of question which might come. Now, here you might get a 60-year-old male female with tense hemorrhagic bullae. So, if you have tense hemorrhagic bullae, which can be given in the history preceded by itchy or urticarial lesions. So, if any of this history is given, old age preceded by itchy urticarial lesions, tense hemorrhagic bullae, then my diagnosis is Bullous Pemphigoid, which is a subepidermal disorder. I do not like this, just telling you the facts. There is so much to explain, but I am sure you have gone through the main lectures where I had explained intraepidermal, subepidermal, why they are tense, why is Nikolsky positive, but here the time is restricted, so I cannot go into the logic of all of this. So, I have to quickly tell you all the facts so that you can quickly recap, but if any of you is unclear about anything, please write it in the chat box. So, preceded by itchy urticarial lesions, tense bullae, they are suggestive of Bullous Pemphigoid, which is my subepidermal disorder. Very good. Now, when I have a subepidermal disorder, this is the DIF finding. See, you do not see the fishnet pattern, but instead you see these linear IgG and C3 deposits on the basement membrane. So, this is my basement membrane zone, and you are seeing immunofluorescence which is linear IgG and C3 deposit at the basement membrane zone. So, any of this being given in the question, please mark Bullous Pemphigoid, right? Now, how to differentiate between pemphigus and pemphigoid? Again, lot of it I have answered already. Usually pemphigoid is seen as at an older age group, you see tense bulla, but remember this mnemonic MENAR. MENAR is mucosal involvement, intraepidermal bullae, Nikolsky sign, acanthocytes and row of tombstone. These are all features of pemphigus group of disorders, not of pemphigoid group of disorders. What are acanthocytes? These are Zank cells. What are Zank cells? Zank cells are acantholytic cells, or they are keratinocytes which have been modified because of loss of surface tension. These are seen in pemphigus, not in pemphigoid group of disorders. Clear? So, MENAR, tense and old age all points towards pemphigoid or subepidermal group of disorders. Clear? Now, in the same topic, this is another question which is commonly asked, where you are told that a person presents with itchy lesions which are recurrent, present on elbows, knees. Very good. So, you have already given me answer. So, if you have itchy lesions which are recurrent, present on elbows and knees, you do not get any history of bullae, but you may get history of enteropathy. They may give you in the question something related to there is diarrhea or something which may be present. So, this may be given in the history, and this is suggestive of Dermatitis Herpetiformis. Dermatitis herpetiformis is a different kind of subepidermal disorder. Here, what is the antigen? What is the antigen in DH? Tell me quickly. So, here you see these recurrent itchy papules which are present on the extensors, on the elbows, and there is history of some enteropathy which may be associated. Then, if you do a DIF here, look at the DIF, it is again different. So, you see papillary tip immunofluorescence here. You see papillary tip immunofluorescence on the tips of the papilla, you see these immunofluorescence. Very good. So, the target antigen here is epidermal tissue transglutaminase, right? Tissue transglutaminase or epidermal tissue transglutaminase is the target antigen here. You do not see any bulla, but you see this. Then how do you treat? The treatment of DH is also asked. You have to give Dapsone and you have to avoid gluten. When I say you have to avoid gluten, what do you need to avoid? You need to avoid BRO, which is barley, rice, oats and wheat. What can you have? You can have MR, which is maize and rice. So, the treatment of DH is give Dapsone and avoid gluten, and you have to avoid barley, rice, oats and wheat. You can eat maize and rice. If the option only involves BRO, then out of this oats is the safest. So, if you have options where you have to pick one out of barley, rice, oats and wheat, then you would allow the patient to eat oats. Clear? Yes, BRO avoid. Wonderful. So, you all know all of this. I am glad you know this. Now, this is another question which is asked in this topic, the target antigens. So, for pemphigus group of disorders, pemphigus vulgaris, I told you it is desmoglein 3. For foliaceous, it is desmoglein 1. Now, these are different subepidermal disorders and you should know their target antigen broadly. So, bullous pemphigoid, pemphigoid gestationis, both have BP 180 and BP 230 as the target. Linear IgA disease or LABD has LAD1 as the target antigen, which is nothing but a subunit of BP 180. EBA and bullous SLE are lower down. So, there the target antigen is collagen 7. If you remember this, I think this is more than enough. For dermatitis herpetiformis, we already discussed that it is epidermal transglutaminase, right? Now, here remember that if sometimes they ask you how do you differentiate between Bullous Pemphigoid and EBA, because you will get a subepidermal split. When you do a DIF, you see linear IgG or C3 deposition. So, to differentiate between Bullous Pemphigoid and EBA, you do salt split. So, what do you do in salt split? In the DIF, you place it with 1 molar NaCl. It splits the basement membrane zone at the level of lamina lucida. Okay, which color marker is better? I am using different colors. You can tell me, is red okay? So, lamina lucida, it splits the basement membrane zone at lamina lucida. So, if you see fluorescence here on the roof, then the disease is Bullous Pemphigoid. Whereas if there is immunofluorescence is seen on the floor, then the then the disease is EBA. So, just remember briefly, to differentiate between BP and EBA, you do salt split technique. It splits the skin at the level of lamina lucida. Perfect. And if it is showing immunofluorescence on the roof, it is Bullous Pemphigoid. If it is showing immunofluorescence on the floor, it is EBA. Clear? Now, this is a mnemonic. Sometimes they give you various disorders and you have to place it in the order of their target antigen. So, we all know Pemphigus foliaceus is first. So, that is first. Pemphigus vulgaris is desmoglein 3, that is next, followed by various subepidermal disorders. So, how do you know where to place which? You have to remember this mnemonic. First we pray, then can eat. So, first is foliaceus, V is vulgaris, pray is pemphigoid, then can eat. So, for C you have cicatricial pemphigoid, and with eat you have EBA or epidermolysis bullosa acquisita, and EB and bullous SLE are the lowermost. The target antigen there is collagen 7, right. So, these are various questions which are asked in this topic. So, you've asked me if this is enough for FMGE. So, at this point, yes, I would say this. So, ideally, I always tell the students you should have revised your notes by now, but ab jo ho gaya, so ho gaya. Ab hum agar itna kar lenge, to at least we will be able to crack 90 to 95% of our questions, right? Because these are the topics which have been asked repeatedly, and that's why we are discussing them at the last minute. Okay, fine. I will not use the red pen. Thank you for your input. Now, since we are talking about bulla, erosions and everything, what are the other questions that are asked in this topic? Now, sometimes you are given a history of drug intake, and then there is history of formation of erosions on skin with mucosal involvement. So, if there is history of drug followed by erosions on the skin or peeling of the skin and mucosal involvement, what do you think of? Yes, you think of Stevens-Johnson syndrome. So, Stevens-Johnson syndrome is a drug-induced reaction commonly seen with painkillers, antibiotics, anticonvulsants and different drugs. Here there is a history of drug intake, and followed by that patient develops a petechial or purpuric rash on the body, which eventually leads to peeling of the skin, followed by development of mucosal involvement, and at least 2 mucosa should be involved. So, this is Stevens-Johnson syndrome, and the score which is used to assess the mortality in SJS is score 10. So, you do a score 10 to assess the mortality in a patient because it is a dermatological emergency. Now, remember, if the involvement is less than 10% of body surface area, you label it as SJS. However, if the involvement is more than 30%, you label it as 10 or toxic epidermal necrolysis. However, in between 10 to 30%, you call it SJS 10 overlap, right. So, you should be able to diagnose, you should know what is score 10, and you should know the difference between SJS and 10. Perfect. So this is drug induced erosions which may happen. Here also if you try to shear off the skin, it comes out, but it is not true Nikolsky, it's false Nikolsky, because here there is no target antigens which are weakening the skin. It is happening because of keratinocyte necrosis and apoptosis. So here what is happening? There is necrosis and apoptosis of keratinocytes. This has also been asked once. Clear? So this is about one more thing. Now, so one of you had mentioned when I showed the first image as Bullous Impetigo. Now, Bullous Impetigo again will present with bullous lesions, but there are differences. There are no mucosal involvement here. You would usually see a child presenting with it. There will be no mucosal involvement, and they would usually give it on the face. So, a child presenting on the face with these crusted erosions on the face, and they can also mention what is the color of these crust? Honey colored crust. So, honey colored crusted erosions can be given. This is impetigo contagiosa, also called as non-bullous impetigo. Clear now? I hope there is no confusion. So, non-bullous impetigo or impetigo contagiosa presents with crusted erosions on the face of a child. Now, the other variant is bullous impetigo, where you see bulla forming. In non-bullous impetigo, there is no bulla. So, bullous impetigo is usually seen in newborns, whereas impetigo contagiosa is usually seen in children, usually toddlers. This is the more commonly given question, impetigo contagiosa. Now, the organism is staph here. Here it is mostly caused by strep, but can also be caused by staph. In developed nation it is Staphylococcus, in developing countries it is Streptococcus. Now, another important question which has been asked, since impetigo contagiosa is caused by Streptococcus, so it is associated with a complication called as Streptococcus glomerulonephritis. So, streptococcal glomerulonephritis is a known complication of non-bullous impetigo. Okay, so no, chickenpox will not be bulla, because in chickenpox you see very small vesicles, you see dewdrop appearance. So, initially there are macules which turns into small vesicles surrounded by erythema. Okay, right. So, that will not be considered in bulla. You do not see a bulla. Bulla is more than 0.5 centimeter. Vesicle is less than 0.5 centimeter. Right? Clear? Now, another thing that they can give you in impetigo is this image of a gram stain. Since it is caused by gram positive organisms like Streptococcus and Staphylococcus, you see cluster or grapes appearance which is seen of gram positive staph and strep. So, along with the image they can give you this gram stain image also, right. We will come to the target sign. Got it? So, these are various disorders which are associated with bulla. Then there is something which is called as Staphylococcal scalded skin syndrome, which is also asked. Now, we just studied that Staphylococcus can cause impetigo. Now, Staphylococcus releases a toxin which is called as ET1 or exfoliative toxin 1. Now, sometimes what is given in the question is that there is a child, usually a newborn, who has some source of infection, which can be an ear infection, infection on the finger. So, some source of infection is given and followed by development of extensive peeling and erythema of skin, right. So, peeling and erythema of skin which follows some source of infection in a newborn. So, this is because this source of infection was Staphylococcus. This Staphylococcus released a toxin which is called as ET1, which went and targeted desmoglein 1 on the skin, leading to peeling and erythema of the skin. So, this ET1 targets desmoglein 1, remember this. This is ET1 toxin released by Staphylococcus. This targets desmoglein 1, which leads to peeling and erythema of the skin. The child is usually sick, admitted in ICU, and you usually get a referral here. Again, you do not get any mucosal involvement here. So, this is Staphylococcal scalded skin syndrome, also referred to as SSSS. Clear? Good. So, any questions on whatever we did till now? These are important questions which have been asked, and I have told you the important topic. Right. So, we will move on to the next subset, which are the group of infections. Ma'am, is this in no, it's not necessary that you get SSS in preterm baby. Preterm babies are more prone to infections, but SSS can be seen also in normal delivered babies. Right, there has to be a source of infection, a portal of entry for Staphylococcus to enter into the body and release exfoliative toxin 1. Right. Now, some important questions. So, we were talking about infections, we did talk about Staphylococcus, but that was more for in the bulla. And now, moving on to further infections, another common question which is asked, a patient presents with pain, tenderness, constitutional symptoms, they can give you an upper limb or a lower limb. So, this can be the image, and they broadly want you to differentiate between two disorders, which is erysipelas and cellulitis. So, tell me, what is the difference? Why do I say this is erysipelas and why do I say this is cellulitis? Yes, so now I want, yes, so erysipelas, to differentiate between these two, both of them will have similar history, pain, tenderness, constitutional symptoms. The only difference which can help you differentiate between erysipelas and cellulitis is that erysipelas has a well demarcated margins, whereas cellulitis is more diffuse. Now, this is because erysipelas is more superficial. There is superficial dermal lymphatics which are affected here. So, it is more well defined, whereas in cellulitis it is the infection reaches up to subcutaneous fat, and since it is deeper, it is less well defined and it is diffuse. Right, otherwise everything is same in both. Erysipelas is predominantly caused by group A beta hemolytic streptococci, whereas cellulitis can be caused by staph and strep both. Right, the treatment remains the same, however, we might need prolonged treatment in cellulitis, but this is the major difference. Yes, C is deeper, E is superficial. C, D, so remember like this, C, D together, so C is deeper and erysipelas has S, superficial. 2S it has, so superficial, right? Good. Now, this is the next infection that they ask you, they give you an image, they tell you that there is a well demarcated patch which is usually non-itchy, mildly scaly. Otherwise, if I have been given just this patch, I can also think of Tinea crurus. But in this infection, it's usually non-itchy, very mildly scaly, and you give a Wood's lamp image which shows coral red fluorescence. So, this is all of you are right, this is erythrasma, and erythrasma presents with well demarcated plaques which may be non-itchy, which may be mildly scaly, but when you do a Wood's lamp you see coral red fluorescence because of production of coproporphyrin 3, because of production of coproporphyrin 3. The erythrasma is a bacterial infection, it is not a fungal infection, and it is caused by a bacteria called as Corynebacterium minutissimum. The common sites can be interdigital web spaces, axilla, groin, but if they ask you the most common site, it is the interweb space, which is the most common. You can see it anywhere, but interweb space is the most common site of erythrasma. Clear? What are the other infections which are caused by Corynebacterium? So, Corynebacterium can also cause pitted keratolysis and trichomycosis axillaris. So, trichomycosis axillaris has mycosis, seems like a fungal infection, but it is not a fungal infection. It is a bacterial infection caused by Corynebacterium. So, these are two other infections which are caused by Corynebacterium. Got it? Now, this is another thing that you get here. What is it? This is anthrax. How do you derive at a diagnosis of anthrax? You are usually given a livestock handler, a cattle rearer, a sheep rearer or something, some livestock handler who presents with this lesion on the extremities. So, you have a crusted lesion or a necrotic lesion which is present on the extremity. So, this is given, livestock handler is given, think of anthrax. Anthrax is caused by Bacillus anthracis, it is a zoonotic infection. It is a zoonotic infection, and this characteristic lesion is called as malignant pustule. It is not malignant, it is not pustule, it is a misnomer, but it is referred to as malignant pustule. So, malignant pustule is a lesion seen in anthrax. Clear? Right. Now, next important topic is approach to alopecias. We might discuss more infections, but probably we'll move to alopecias first. So, next set of topic that you get is alopecias, and alopecias can range from various things, but I have categorized them so that we can differentiate it on the exam. So, when you have patchy alopecia, so sometimes they give you patchy alopecia. So, when you have patchy alopecia, you think of following things: alopecia areata, tinea capitis, trichotillomania, and moth-eaten alopecia of syphilis, right. So, when you have patchy alopecia, think of these 4 DDs. Now, first we will rule out moth-eaten alopecia. Whenever they want to give you moth-eaten alopecia, which they will not give you, they will give other history of secondary syphilis, right. Rest of the 3 we will discuss. So, now if I have patchy alopecia, now we will not cover the questions today because we already did it in the November session. We had given you questions and discussed on the basis of questions. Here today we are discussing the important topics, right. I am telling you all the questions which are given, but today we will not be dealing it in the form of questions, right. So, now if you have patchy alopecia, then there can be 2 scenarios. So, first can be this scenario where you are seeing gray scales, where you are seeing broken hairs, and you do not see a very smooth patch. You see a patch which has gray scales, broken hair, but it is not very smooth. So, this is gray patch kind of tinea capitis, right. So, these scales which you see are actually the fungal colonies. These are the fungal colonies which are evading the hair from the outside. So, grey patch of tinea capitis is a type of ectothrix, and these grey scales are actually fungal colonies. So, fungus is outside the hair, so it is called as ectothrix. The common organism causing grey patch tinea capitis is Microsporum canis, right. However, the other scenario can be where you are given a smooth patch of alopecia, totally asymptomatic, no itching, nothing, no pain. The patient just notices a smooth asymptomatic patch, and you might see grey hair on periphery. If you see grey hair on periphery, you see smooth asymptomatic patch, then you think of alopecia areata. Alopecia areata is an autoimmune condition, and this presents with this kind of smooth bald patch with preserved grey hair. Clear? Now, how do you differentiate? So, first you look at it clinically and it is easier to differentiate. Now, when we talk about grey patch tinea capitis, few more inputs that you should be knowing. Since the grey scales are actually fungal spores, this type of tinea capitis is responsible for outbreaks in school. So, grey patch type of tinea capitis is responsible for outbreaks in school. Also, since the fungal spore are outside, it shows positive Wood's lamp fluorescence, and usually you see a greenish kind of fluorescence here. So, Wood's lamp fluorescence is positive and you see greenish color fluorescence here, right. Now, How do you differentiate it based on tests? So, this can be given. So, this is the hair shaft and these are the fungal spores which are there on the outside. So, this is ectothrix. So, you can do a KOH of the hair in the case of Tinea capitis and you see spores which are outside the hair shaft. In alopecia areata, if you do a dermoscope or if you look at the periphery of the patch, you see something which is called as exclamation mark hair. Exclamation mark hair is seen on the periphery of the lesion, which is very characteristic of alopecia areata. In alopecia areata, remember few other things. You have on histopathology, you have swarm of bees appearance. If you do a histopathology, there is lymphocytic infiltrate which is called as swarm of bees appearance. Also in alopecia areata, you may be given a history of going grey overnight, because in alopecia areata my immune system does not target the white hair. So, white hair are preserved, black hair are gone. So, patient usually says that I am going grey overnight because all the grey hairs are preserved, right. So, this is important about alopecia areata. How do you treat? For Tinea capitis, you have to give griseofulvin, which is my drug of choice. So, my drug of choice is griseofulvin. Remember, in Tinea capitis, you do not treat with topical preparations, you always give oral preparation, and griseofulvin is my drug of choice. For alopecia areata, my treatment of choice is intralesional steroids. So, you give intralesional steroids in the patch. Apart from that, you can give contact immunotherapy. You can also use mini pulse steroids and you can use immunosuppressants based on the severity of the condition, right. So, this is all that you should be knowing. Another important question in patchy alopecia is something like this. You may be given an image where you do not see any scales, but it is not a smooth patch. In fact, what are you seeing? You are seeing hair shafts of different length. So, you see broken hair shafts of different length on the patchy alopecia that you see. So, there is a patchy alopecia, but again here there are no scales, no smooth lesions, just broken hair shaft of different length, and you may get a brief psychiatry history in the exam, that the child is withdrawn, the child is not social or something like that, and so you think of trichotillomania. So, trichotillomania is a psychotic disorder. It is treated using cognitive behavioral therapies or antipsychotic medications, right. So, all patchy alopecias are different and it is very easy to differentiate between them, right. Another sign that you see here is called as Friar-Tuck sign, because of this appearance of different lengths of hair seen on the scalp, right. So, this is trichotillomania and this is how you differentiate. Now, since we are talking about Tinea capitis, I quickly wanted to revise different forms of Tinea capitis. So, black grey patch we have already discussed. There are 3 more forms of Tinea capitis. So, Tinea capitis can be broadly divided into non-inflammatory and inflammatory types. Non-inflammatory is caused usually by anthrophilic species, so there is less inflammation, right. In that we have grey patch which we have already discussed. The other one is black dot. Students, are you there with me? Is my pace okay? Do you want me to slow down or anything? Are you getting what I am teaching or is it too much? Okay. Perfect. Thank you so much for your inputs. Okay, great. Perfect. So, coming to other form of Tinea capitis. So, black dot Tinea capitis is a form of Tinea capitis which is actually a endothrix. By endothrix, I mean that the hair shaft is invaded by the fungus from the inside. So, you do not see spores on the outside. Since there are no spores on the outside, it is Wood's lamp will be negative. So, Wood's lamp fluorescence will be negative here. Now, it is endothric. So, the hair has invaded the shaft from inside. What happens? There is swollen hair shafts and hair shafts break from the surface. So, these black dots that you see are nothing but swollen hair. Okay, perfect. Okay, I will use Hindi if nobody has any problem. तो मैं बीच बीच में हिंदी बोल सकती हूँ. I just don't know whether the population that I am catering to, do they understand Hindi or not. So, if you all are comfortable with little bit of Hindi, I'll add Hindi in between. So, swollen hair shafts are seen which appear as black dot. Right. The common microorganism causing this is Trichophyton rubrum. Initially, M. canis was the most common organism causing Tinea capitis. Now, it is Trichophyton rubrum. Right. Okay, perfect. Now, the next form of Tinea capitis, these two forms are inflammatory forms because they are caused by zoophilic species. Right. So, what are these forms? So, one of them is Cheiron and this is Favus. Important things about Cheiron. Cheiron will present with boggy swelling. So, if there is anything in the question which is given about boggy swelling, think of Cheiron. Boggy swelling on the scalp, broken hair shafts, pustules, lymphadenopathy, everything. So, because there is a severe inflammatory reaction here and here if you do a KOH it will come out to be negative because जो inflammation है वो मेरे fungus को भी target कर देता है तो fungus दिखता नहीं है और ये जो boggy swelling हो रही है pustules है ये सब ये सिर्फ inflammation का sign है. The organism which causes this is Cheiron, Verrucosum and Mentagrophytes. Big names, right? Here also Wood's lamp fluorescence will be negative, right? Coming to Favus, Favus is caused by Trichophyton schonleni. Favus has cup-shaped crust which are called as scutula. Scutula or cup-shaped crust are seen and here you see a positive Wood's lamp fluorescence because these crusts are again fungal colonies. तो जहाँ fungus बाहर होगी वहाँ fluorescence मिलेगा, जहाँ fungus बाहर नहीं होगी वहाँ fluorescence नहीं मिलेगा. Easy to remember. Okay? Okay, I'll use English only. Perfect. So, these are various forms of Tinea capitis and we have already discussed the treatment for Tinea capitis remains same. You use griseofulvin orally. Right. Now, moving on to few basics questions. So, basic, this is very basic. If you have studied even dermatology a little bit, you would have studied these. What are the layers of the skin? So, you all know, you should know these layers from top to bottom. Corneum, lucidum, granulosum, spinosum and basal. I will just discuss the important points. Stratum corneum is my dead layer of the skin. Here there are no nuclei, cells are flat, dehydrated, no mitosis. This is the dead layer of the skin. Its only function is barrier function. So, the topmost layer is dead and it is dead for a purpose because it maintains the skin barrier, right? Okay. So, yes, you are right. Let's get sunburnt, not just come. Okay, I'll just do that after a while, what you asked, alopecia of chemotherapy. So, stratum corneum is the topmost layer and the mnemonic to remember these layers is come, let's get sunburnt. First layer is dead. Now, second layer is my stratum lucidum. Now, lucidum remember is only present in palms and soles. Lucidum has L, palms and soles also has L. This is called as clear looking cell because of presence of refractile granules of L-edine. So, refractile granules of L-edine are there which gives this layer a very clear looking appearance and this layer is only present in palms and soles, right. Next layer is stratum granulosum. In stratum granulosum, yes, in stratum granulosum you see granules You can see Odland bodies and keratohyaline granules. So, this is the layer where the granules are formed, and these granules have different functions. Now, next layer is stratum spinosum. Stratum spinosum means spines. What are these spines? These spines are nothing but desmosomes, which are quite apparent in this layer because this is the thickest layer of the epidermis. So, this is the thickest layer. My desmosomes are appearing as spines here, and this is the layer which is giving the maximum support to the epidermis because it is the thickest layer of the epidermis. The last layer is stratum basale, and this is my stem cell of the epidermis. This is where my epidermis is being formed from. It is a single cell layer, and this is the mother layer of the epidermis because from here you usually from here only the epidermis is formed. So, epidermis is formed from from bottom to top. So, if I have a preterm baby, I will not have stratum corneum in a preterm baby, right, because my skin is formed from bottom to top. So, topmost layer will not be formed, right. So, these are various layers of the skin. Now, somebody asked me about alopecia and chemotherapy. So, in patients who have chemotherapy, they have diffuse alopecia, which is called as anagen effluvium because chemotherapy is targeting all the actively dividing cells. In my hair, anagen phase is the phase which is the most actively dividing. Now, almost 90% of my hair are in the anagen phase. So, when a patient removes gets chemotherapy, this anagen hair is targeted, and so 90% of the anagen hair falls off, and so the patient is almost bald, and this is called as global alopecia. So, global alopecia is something that you see with chemotherapy patients, and this is because of shedding of anagen hair. So, it is also called as anagen effluvium. Clear? Perfect. Now, coming to the cells in epidermis. So, we have different cells in the epidermis. There are 4 cells in the epidermis. The most pronounced is keratinocytes, which cover almost 90% of my epidermis. This is present in all cell layers, right, and it is derived from ectoderm. It is present in all cell layers and it is derived from ectoderm. The next important cell that we have is called as Langerhans cells. Langerhans cells is present only in stratum spinosum. It is derived from mesenchyme, and this is my antigen presenting cell, and this is the cell which has Burbeck granules, right. Burbeck granules, stratum spinosum, mesenchyme, antigen presenting cells. These are all important things about Langerhans cells. The next important cell is melanocytes. Melanocytes are present in stratum basale. These are my pigment forming cells which are derived from neural crests, right, and they transfer their melanin to 36 keratinocytes around them. So, my EMU ratio or epidermal melanin unit is 1:36, where there is 1 melanocyte per 36 keratinocyte. But this is what my melanocyte is transferring melanin to, right. Melanocytes is this. Then coming to my last cells, which are Merkel cells. Merkel cells are again present in stratum basale, and they are slow adapting touch receptors. They are slow adapting touch receptors. Their origin is still unclear. So, usually you are not asked. So, these are the 4 layers, and you should know about Odland bodies are present in stratum granulosum. Odland bodies are actually a type of granules that you see in stratum granulosum, right. So, these are 4 layers. Now, common thing that you are asked is which cell is not seen in stratum basale. So, that would be Langerhans cells because keratinocytes is present in all cell layers. Which cell is a slow adapting touch receptor? That is Merkel cell, which is derived from where, which we have all discussed. So, these are the common things, common questions which are asked about my different cells in the epidermis, right. Moving on. I'll skip this. Okay, this is something you should know. Just one question. What is lichenification? Lichenification is a skin change in which there are three components: pigmentation, increased skin markings, and thickening of skin. And this is seen in lichen simplex chronicus or neurodermatitis patients. If you do a histopathology here, you see acanthosis or thickening of stratum spinosum, right? So, pigmentation, increased skin markings and thickening of skin is what is called as lichenification. Yes, telogen is related to stress, you are right. Telogen is related to lot of things. It can be mental stress, it can be physical stress, it can be physiological stress like pregnancy. So, yes, telogen is related to stress, and telogen effluvium usually happens 3 months after the stress, right. Okay, these are two lines which are commonly asked. You are told to identify the lines. It is very easy to identify. These are Blaschko's lines and these are Langer's lines. Blaschko's lines are all curvy. So, you have C, S here, C here, so all curvy lines. So, if you look at the lines, so they will be all curvy and S-shaped, spiral shaped lines. Langer's lines are more straighter. So, they are forming either oblique lines or straight lines. Langer's lines are called as relaxed skin tension lines. They follow orientation of collagen and muscle. Now, these Langer's sign, remember anger here. Since anger is not constant, so these are the lines which are not constant. They will keep changing with the change in orientation of collagen and muscle fibers, whereas Blaschko's lines are lines of embryonic development and they are constant. C for constant. So, they do not change. They have a strict midline demarcation, Blaschko's lines. What is the relevance of giving Langer's lines? Langer's lines helps in giving incision, because if you give incision parallel to the Langer's line, it helps in better healing of the lesions, because you are giving an incision along the orientation of collagen and muscle fibers, right. So, you should be able to identify these two lines in dermatology. Clear? Okay. Moving on to genital ulcers, another important topic. Now, there are 5 genital ulcers that we should be able to differentiate between. Okay. So, what are the causative organisms is what you should be knowing: syphilis, Treponema pallidum, LGV, Chlamydia trachomatis, chancroid Haemophilus ducreyi, Donovanosis, Klebsiella granulomatis, and HSV is the organism for herpes. Now, I will come back to this table. I will quickly show you various images and how to identify. So, when they are talking about syphilis, they will usually give you a single, painless, indurated ulcer. So, if there is single, painless, indurated ulcer with shorty lymph node, you have to think of syphilis, and the primary stage of syphilis presents with chancre, right. So, chancre is something that you see with syphilis, which is caused by Treponema pallidum. It is a single, painless, indurated shorty lymph nodes, right. Then another image that I give you in syphilis is this, where they tell you that it is a truck driver and on his hands you have these patches. So, if truck driver with these lesions come, think only of secondary syphilis. These are nothing but macular and papillary syphilids which are present on the palms and soles of a patient who has got this STD, right. Then how do you identify it as Treponema pallidum? It cannot be stained. So, what do? Do you do dark ground microscopy here? Yes, you are right. There is when you poke these lesions, it is tender, the patient winces in pain because of end arteritis obliterans, right. Then how do you diagnose this? You do a dark ground microscopy where you see these fluorescent wavy organisms which are Treponema pallidum. How do you treat? You have to give benzathine penicillin. See, syphilis in itself is a 4-hour lecture, But these are some of the very important things that I could talk about in syphilis, right? So, benzathine penicillin, Treponema pallidum, dark ground microscopy, single painless indurated ulcer with shorty lymph node, or this palm sensoles. Another yes, this is also what I wanted to discuss. Another manifestation of secondary syphilis is condyloma lata. So, you should be able to differentiate it from condyloma acuminata. So, condyloma lata is a manifestation of secondary syphilis where you see these moist looking plaques on flexures. When you have this moist looking plaques on flexures, think of condyloma lata. Condyloma acuminata on the other hand are nothing but anogenital warts. So, they will present with that rough hyperkeratotic papules. Here you see these moist plaques which are there, which are nothing but macerated papular syphilids on the flexures. These plaques are highly infectious, right? So, these are highly infectious. So, condyloma lata is another thing that you should be knowing about in syphilis. Moving on to the second set of genital ulcers, when you have something like this, which is coalescing vesicles with polycyclic erosions. So, in the history, you are given coalescing vesicles, polycyclic erosions, or history of recurrent lesions. So, then you think of herpes genitalis. Herpes genitalis is caused by HSV, or and here HSV2 is more commonly implicated than HSV1, and herpes simplex has a tendency to recur. So, recurrent lesions, coalescing vesicles, polycyclic erosions, which are painful, which are associated with lymphadenopathy, and very importantly short incubation period. With syphilis, the incubation period is 9 to 90 days. Here the incubation period is 2 to 5 days. So, a patient who had indulged in sexual intercourse develops this. Remember, you do not see an ulcer in herpes genitalis. Usually you do not see an ulcer. So, you may be given a similar history of multiple ulcers which are painful, which are present, which are soft on the genital area, then it becomes chancroid. Chancroid and herpes both have short incubation period, both are painful, both present with multiple lesions, but chancroid will present with ulcers, whereas herpes will present with vesicles and erosions. Clear? Yes, bilateral tender lymphadenopathy is seen in this. Then what do? You do a Zank smear here. This is another question. Zank smear is done for pemphigus group of disorders where you see acanthocytes or Zank cells, and it is done for herpes group of disorder where you see multinucleate giant cell. In the last exam, there were 2 questions on herpes genitalis. So, multinucleate giant cells or MNGs are a feature of HSV, right? And how do you treat? You give acyclovir. Clear? So, this is about herpes genitalis. So, then what is the next genital ulcer? Next genital ulcer is multiple ulcers which are painless, which are painful with a soft base which is not indurated with buboes or lymphadenopathy. So, multiple painful soft base, incubation period again short 2 to 5 days, you think of chancroid. Chancroid is caused by Haemophilus ducreyi. Okay, Haemophilus ducreyi. How do you treat chancroid? What do you see here? You do a gram stain and you see school of fish appearance or railroad track appearance. So, railroad track appearance, school of fish appearance is classical for chancroid, right? How do you treat? Give me treatment of chancroid, right? So, see, it is different from herpes. Short incubation period, painful, multiple lesions are same for both, but here you see ulcers, there you see vesicles and erosions. Yes, you are right. The treatment for chancroid is azithromycin. Clear? Now, Here also you see buboes, in LGV also you see buboes. What is the difference? In chancroid, the buboes are usually unilateral, associated with ulcer. In LGV, you usually see bilateral lesions, you do not have an ulcer here. Clear? Yes, you can also give ceftriaxone injections. Then the fourth kind of ulcer presents with beefy granulomatous ulcer, which is painless but bleeds easily to touch. So, not LGV, this is not LGV, this is donovenosis, you are right. So, donovenosis will present with beefy granulomatous ulcer, which is painless, long incubation period, and it bleeds easily on touch because it is very granulomatous, right. Here you do not have lymphadenopathy, you do not see lymph nodes here. What you see here are called as pseudobuboes. What are pseudobuboes? These are presence of these ulcers on the lymph nodes. So, lymph nodes are usually not involved in donovenosis, but you see pseudobuboes here. So, you are right, this is also called as granuloma inguinale, right. So, this is donovenosis. In donovenosis, what is the test that you do? You do this GIMSA stain, where you see safety pin appearance. Safety pin appearance is seen on GIMSA stain. Clear? Yes, you are right. The treatment, the organism is Klebsiella granulomatis, and the test that you can do apart from this is nucleic acid amplification test. So, when you see an ulcer which is very granulomatous and bleeds easily on touch, think of donovenosis. Right. LGV I have not mentioned here. LGV does not present with ulcers. I will quickly revise LGV with you. LGV does not present with ulcer because ulcer is a very transitory stage. It presents with buboes, which are bilateral, painful, suppurative, and patient almost limps with pain. So, bilateral painful suppurative lymphadenopathy, which can lead to saxophone penis in males and estheomine in females. So, LGV is associated with lymphatic involvement. It is called as lymphogranuloma venereum. Lymphogranuloma venereum. It mainly involves the lymphatic tissue, right. So, these are various ulcers, and I think I'll just go back to that table and see if we have discussed all the important points. Yes, we have. Right. Now, yes, another important thing, in chancroid, the ulcers have an undermined edges. In dermatology, when we talk about undermined lesions, you have to think about these things: chancroid, pyoderma gangrenosum, and there is one more undermined ulcer, which is yes, TB chancre. So, these are three ulcers which have undermined edges, for which you define undermined edges in dermatology: chancroid, pyoderma gangrenosum, and TB chancre, right. So, this is all that you should be knowing about genital ulcers. Since we are talking about STIs, quickly revising a few other topics in STIs. So, another question that you get is on urethral discharge. So, urethral discharge, if it is copious, thick, purulent, and associated with symptoms, you think of gonococcal urethritis, which is caused by Neisseria gonorrhea. So, basically urethritis is divided into gonococcal urethritis and non-gonococcal urethritis, right. Non-gonococcal urethritis is caused by Neisseria gonorrhea. Non-gonococcal urethritis is caused by chlamydia, mycoplasma, Gardnerella, trichomoniasis, HSV. So, all these comes under non-gonococcal urethritis. Non-gonococcal urethritis will present with watery looking, scanty, thin discharge. and here usually there are no symptoms, right. So, if you have this thick purulent discharge, think of gonococcal urethritis. What do? You do a gram stain. If you do a gram stain, you see this in gonococcal urethritis. So, if you do a gram stain, obviously you would see a lot of PMNs in both, in gonococcal and non-gonococcal urethritis. But in gonococcal urethritis, you also see this gram negative diplococci, which are nothing but Neisseria gonorrhea, which are present inside the PMNs and outside the PMNs. So, these gram negative diplococci, which are present in pairs, is characteristic of gonococcal urethritis. So, PMNs on gram stain will be seen in both gonococcal and non-gonococcal urethritis, but gram negative diplococci is a feature of gonococcal urethritis. So, bean kidney appearance or diplococci, right. So, these are two other, this is urethritis, which is again asked. The next thing that is asked is anogenital warts, which I told you is condyloma acuminata. I was telling you it presents with these rough hyperkeratotic looking papules. You have to identify it, and you should be knowing that anogenital wart is also called as condyloma acuminata. Now, sometimes anogenital warts, they are caused by low risk HPV types or high risk HPV types. Low risk HPV types is HPV 6 and 11, high risk is 16, 18. These high risk HPV types sometimes can cause something called as joint condyloma acuminata, which is also called as, what is it called as? Giant condyloma acuminata is also called as, quickly, they give you this image and they ask you what it is. Yes, Buschke-Lowenstein tumor. So, Buschke-Lowenstein tumor is nothing but a giant condyloma acuminata, right. This is caused by high risk HPV types. Okay. So, that was important questions on STIs. Now, we will move on to a different topic. What is it? I will give you a brief history. I have a 14-year-old child presenting with red, small, mildly scaly plaques on trunk preceded by streptococcal throat infection. So, if I have a streptococcal throat infection followed by development of these mildly scaly small plaques on the trunk, you have to check that in the schedule here. So, this is guttate psoriasis. So, this is guttate psoriasis. So, this is a different form of psoriasis because the lesions are smaller here, less scaly here, does not involve extensors mainly involves the trunk, mainly involves the kids, but the giveaway point here is streptococcal infection. And that is why the treatment of guttate psoriasis is nothing related to psoriasis. You give antibiotics. The treatment is either antibiotics, and if it is very recurrent, you do tonsillectomy, right. And this appearance is also called as raindrop appearance. There are lesions which are distributed all over the trunk in raindrop pattern. Okay, so this is guttate psoriasis, and the treatment here is antibiotics. You can do an ASLO, you can do throat swab to look for streptococcal carriage here, right. Then what is this? Quickly, what is this sign? Very good. So, this is Koebner's phenomena, also called as isomorphic phenomena. Koebner's phenomena or isomorphic phenomena. Now, this is seen very commonly in psoriasis. True Koebner's is seen in psoriasis, lichen planus and vitiligo. Another important question. So, true Koebner's is seen with this, pseudo Koebner's is seen with molluscum contagiosum and warts. Pseudokoebners is seen with molluscum contagiosum and warts because of seeding of microorganisms or autoinoculation of microorganisms. But true Koebners is a feature of psoriasis, LP and vitiligo. What is Koebners? You scratch and you develop lesions of similar morphology along the scratch lines, right? Good. Then sometimes you are given something like this and you need to differentiate what is happening where. So, you are given a toenail or a fingernail with some yellowish discoloration. So, if you are given a yellowish discoloration, look for following signs. So, here you are seeing pits. And what do you see here? So, if you see here, there is a yellowish discoloration, but there is also an orangish reddish patch here. So, these are oil. This is oil drop sign. So, you have to differentiate between onychomycosis and nail psoriasis. So, onychomycosis will present with yellowish discoloration only with some amount of subungual hyperkeratosis. But if you see these pits which are seen or you see these oil drop sign, you think of nail psoriasis. So, when you have a patient of nail psoriasis, you may be given a history of psoriatic patches elsewhere or you may just be given the nails. Now, so if you see pits or oil drop sign, think of psoriasis. Now, in pits, the pits here are deep, they are random, they are irregular pits. Pits are the most common finding that you see in nail psoriasis. However, nail drop sign is the most specific findings. Why is it specific? Because if you see oil drop sign, you know we are dealing with psoriasis. But pits can be seen on other conditions also, like where pits can be seen in alopecia areata also. But here the pits are geometrical. They are small pits, very well aligned pits, something like this. Whereas in psoriasis, you have deep, random, irregular pits. Clear? So, you should be able to differentiate between nail psoriasis and onychomycosis. Oil drop sign is also called as salmon patch. Correct? So, moving on, then you are asked about the histopathology. Now, this is a very common histopathology image which is given in the exam and you are asked what it is. So, it is quite easy. Yes, polish is for nail psoriasis. You are right. Let's see. If you are just given this image and you are asked the histopathology, what disease is it specifying? So, you would be given very few histopathology images. So, this is one of them. Obviously, I was discussing psoriasis. So, you know that this is the psoriatic histopathology. But what are the important points in psoriatic histopathology that you should be knowing? Very good. You are absolutely right here. On the stratum corneum, you see hyperkeratosis, you see parakeratosis, and you see moon rose micro abscesses, which are nothing but collection of pus, right. So, this is my stratum corneum which shows hyperkeratosis, parakeratosis. What is parakeratosis? Parakeratosis is retention of nuclei. I told you stratum corneum does not have nuclei, but if there is retention of nuclei in the stratum corneum, we call it parakeratosis. Moon rose microabscesses is collection of neutrophils here. What happens to stratum granulosum? What happens in stratum granulosum? Tell me. Good. What happens to stratum granulosum? And then coming to stratum spinosum. So, yes, stratum granulosum is absent. There is no stratum granulosum here, not absent, absent. Okay. Then what is happening in stratum spinosum? There is acanthosis, increased thickness, and there are Kogogs psoriasiform pustules. So, or Kogogs pustules, which is another collection of neutrophils, is seen in stratum spinosum, right. Then you come to rete ridges. Rete ridges are elongated, club shaped and appears like camel foot. So, camel foot appearance is characteristic of psoriasis. So, you have these retail ridges which are elongated, cup shaped, just like a camel foot. So, camel foot appearance is something which is very characteristic of psoriasis. So, there are lots of other features, but these are the ones that are asked. That Monroe's microabscesses, where is it located? Kogo's fungiform pustules, where is it located? What happens to stratum granulosum, and this camel foot appearance. So, when you look at this image, you should be able to identify that this is a histopathology of psoriasis, right? Okay. Moving on from psoriasis, another common question. A patient presents to you with a itchy rash on thigh which is recurrent. Patient applies some over the counter medicine, improves but relapses. So, what is it? So, this is a recurrent rash which the patient is having on the thigh. He applies some OTC medicines, it improves and then relapses. Yes, in psoriasis there is rapid recycling of layers from bottom to top. Tell me the diagnosis here. Absolutely correct. Yes, this is Tinea Incognito. So, it is unlike tinea because you do not see proper annular scaly lesions here, but the giveaway point is this OTC medicine, over the counter medicine which the patient is applying. It improves but relapses. Usually these OTC medicines are steroids, so it takes care of the inflammation, but the fungus does not go, so it tends to recur. So, Tinea Incognito or hidden tinea is something which is commonly asked as a diagnosis. You are given an image or a question like this. Okay. Very important or common question which is again asked in the exam. I know you all must be knowing it thoroughly, so I will quickly go through it. So, you are given a farmer or a rose gardener who presents with these asymptomatic lesions which are papules and nodules along the lines of lymphatic. So, in a linear distribution you have papules or nodules. This is called as rose gardener's disease or sporotrichosis. Sporotrichosis is a type of subcutaneous mycosis. It is caused by Sporothrix kenkai, usually seen in farmers and rose gardeners where there is lymphatic spread. So, along the course of lymphatics, you see these linear distribution of papules and nodules. When you do a histopathology, you see asteroid bodies, and if you do a PAS stain, you see cigar shaped bodies. How do you treat? The treatment involves using itraconazole, potassium iodide, or even terbinafine can be used, right. So, this is a very common question which is asked, and I am sure you all know about it, and these are the important points that are commonly asked. Now, the next important question which is asked in subcutaneous mycosis is this. What is the diagnosis here? Perfect. So, yes, this is mycetoma. Mycetoma has a triad. There is tumefaction or swelling of the skin. There are multiple sinuses, and from these sinuses you see grains coming out, and this is all painless. So, painless lesion on the foot of a farmer presenting with swelling, with sinuses, with grains, this is mycetoma. Now, in mycetoma you should remember that there are two types of mycetoma, eumycetoma and actinomycetoma. Actinomycetoma is caused by fungus, so it is more prolonged. Here the granules are black in color. So, if they ask you about black granules, they are talking about, I am so sorry, I am talking about eumycetoma here. So, eumycetoma is caused by fungus, and here you see black granules, and usually they ask you if black granules are present with this, what is the causative organism? It is Madurella mycetomatis, which is a fungus causing mycetoma. Actinomycetoma on the other hand is caused by bacteria. Here the grains are usually red in color. So, if they talk about red grains, think of actinomycetoma. Clear? So, mycetoma should be clear, and eumycetoma is, yes, eumycetoma is fungus, I am so sorry. So, eumycetoma is fungus, here you see black granules, and so Madurella mycetomatis is the common organism here. Clear? And actinomycetoma is caused by bacteria. So, it is because of the color of the granules. You can also do a KOH, you do a gram stain. In actinomycetoma, you see very slender filamentous organisms. In eumycetoma, you see proper fungus, septate fungus which is seen. Clear? So, this also is something which is very commonly asked, and you should be able to differentiate. Sporotrichosis, mycetoma, and sometimes chromoblastomycosis is also given, that is another subcutaneous mycosis, where you see copper penny bodies or sclerotic bodies, you see pigmented fungi there, right. Then some of HPV we have already discussed, and yet in Anogenital Warts. So, HPV, you know, HPV strains are commonly asked, so you should know these strains. You can remember it with the mnemonic DSP come eat a burger. HPV 1 caused by deep plantar, 2 causing superficial plantar, 3 plain warts which is caused by 3 and 10. These are common ones which are asked, so I am putting it here. 4th is common, 4 to 27. 5th is EDV anogenital, we have already discussed. So, DSP come eat a burger is the mnemonic to remember various strains of HPV which are commonly asked. There are more than 200 strains, but you are not going to remember all of them, right. Now, in HPV you should know 2 main types. This is Verruca vulgaris or common warts, 4, 2 and 27. So, you should be able to differentiate between them. Sometimes they just give you an image and they ask you what is the HPV type which is associated with it. So, if you see these hyperkeratotic papules, these are Verruca vulgaris or common warts. However, if you see this, these are plain warts or flat warts or Verruca plana. So, then this is seen usually on face, usually seen in immunocompromised individuals, patients on chemotherapy. They have these multiple flat looking warts which are present on the face, right. Clear? So, HPV subtypes are important, you should be able to differentiate. If you do a histopathology of HPV, what do you see? On histopathology of HPV, you see coelocytes or clear looking cells, just something like this, right. So, coelocytes are a feature of HPV on histopathology. Okay. So, what is this? I have already written. Where is target lesion seen in? So, target lesion is something like this, where you have 3 zones, a central zone of necrosis followed by edema followed by erythema. What is the name of this disorder? What is it called? Where do you see target lesions in? So, target lesions are seen in Erythema Multiforme, EM. You are seeing multiple forms here. So, Erythema multiforme or EM presents with target lesions. The most common cause of EM is infectious, which is HSV. The second common cause is drugs, right. So, infections and drugs can cause a reactionary pattern called as EM on the skin, which presents with target lesions. So, this is what is asked. You may be given a history of herpes and then they ask you that these lesions are present. What are these? So, herpes or drug intake can lead to this kind of target lesions, and these are called as erythema multiforme, right. What is this? You have a patient on which you see unilateral distribution of painful vesicles which are present. What is the diagnosis? Yes. So, this is herpes zoster, and herpes zoster is caused by varicella zoster virus. The same virus which causes varicella in kids causes herpes zoster in adults. The typical feature of herpes zoster is unilateral dermatomal distribution of painful vesicles. So, this is very, very important. Painful vesicles present on a unilateral dermatomal distribution is a feature of herpes zoster. Right now, what happens here is this is not an infectious condition. This happens because of reactivation of virus in dorsal root ganglion. So, because of reactivation of the virus along a particular nerve, you see this reactivation of virus and patient develops this. How do you treat? You give acyclovir 800 milligram 5 times a day. So, you give very, very high doses of antivirals here. 800 milligram 5 times a day of acyclovir is given. Right. So, this is another very important question which is asked in the exam. What is this? Yes. Here I have 2 lesions which are of the same condition. You have a lesion which is asymptomatic. In this case, it is present on the buttocks. In that case, it is present on the face, and you have done a sign. Yes, so this is lupus vulgaris, and an easy way to diagnose lupus vulgaris is, you guys are going great. You know everything. So, I'm very, very glad that just by looking at the image, you are able to identify certain dermatological conditions. So, lupus vulgaris, the classical feature is expansion at one end, atrophy in the center. So, when you see a plaque which is expanding peripherally but showing atrophy in the center, think of lupus vulgaris. Another hint here was there is a dioscopy image, and on dioscopy image you see yellowish apple jelly nodules. So, because it is a granulomatous conditions. So, apple jelly nodules on dioscopy is a feature of lupus vulgaris. So, apple jelly nodules on dioscopy is seen in lupus vulgaris. Lupus vulgaris is the most common form of TB that you see in adults, right? And typically it will present with this advancing peripherally and central atrophy. Okay. The other form of TB which is asked is this, which is the most common form of TB in children. What is this? I am sure you will be able to diagnose this also. Yes, this is scrofuloderma. Scrofuloderma spreads by contiguous spread. Contiguous spread. So, what do I mean by contiguous spread? There is an underlying focus of TB which is there either in the lymph node or on the bone or in the lacrimal gland, and from there the TB comes on the skin. So, contiguous spread is known as scrofuloderma, most common form in children. The most common site is cervical lymph node. The most common form is cervical lymph node, right. So, this is the form of TB that you see in children, right. Clear? Yes, you can do an anti-gravity. Now, sometimes you may get confused here when you see this. So, look for an underlying lymph node, look for an underlying abscess which will be given, which will help you point towards the diagnosis of scrofuloderma. Now, when we are talking about cutaneous TB, another important question that comes is from tuberculids. What are tuberculids? So, tuberculids are a hypersensitivity reaction. So, what question you get? All are true about tuberculids except. So, in tuberculids, these are hypersensitivity reaction. There is a Mycobacterium TB focus which is there somewhere in the body from where the antigens are released. My body mounts an hypersensitivity reaction which is a type 4 hypersensitivity reaction against it, and that leads to development of lesions on the skin. So, when they say all are true about tuberculids, you should know about the criteria of tuberculids, that there is a primary focus elsewhere. Because there is a positive immune response which is generated, obviously my montus will be positive here. So, this is usually given that all is true except, and in which they give you negative montus. So, tuberculid, the feature is the montus is positive. If you do a histopathology, you see a tuberculoid histology, but if you do a culture, it will be negative because it is not a actual TB infection, it is a hypersensitivity reaction. And another important criteria is the treatment remains the same, that is you give ATT and the patient gets treated. So, these are the criteria of tuberculids that you should be knowing. Right. Now, in tuberculid, there are two forms of tuberculid that you should be knowing, which is lichen scrofullosorum and papillonecrotic tuberculoid. Lichen scrofullosorum is a micropapillar form. Here you see lesions on the trunk. You see these perifollicular grouped lesions which are present on the trunk. There is no scarring, and on histopathology you see superficial dermal granules. Whereas papillonecrotic tuberculosis is seen in adults, it is seen on extremities, and this will heal with scarring. Usually they are asked about the criteria of tuberculosis which you should be clear about, right? Very good. So, you know everything. So, this is about tuberculosis. The treatment remains the same and nobody asks you the treatment here. Moving on to leprosy, another important topic, and again I will be discussing the important thing. Leprosy in itself is a long topic. So, one, you should be able to differentiate between different spectrums of leprosy. Second, you should be able to differentiate between type 1 and type 2 reaction, and third, you should be knowing about the treatment of leprosy. So, these three are the most important topics in leprosy. So, coming to the spectrum, so when they want to know about indeterminate leprosy, remember indeterminate leprosy does not come into Ridley-Jopling's classification. Indeterminate and pure neuritic does not come under Ridley-Jopling classification. Indeterminate leprosy will usually present with a single lesion. There will be no infiltration, no loss of sensation, no FB, because any of this it happens, it becomes determinate leprosy. However, when you do a histopathology, you see a slight perineural or periappendigeal infiltrate. This is a form of leprosy which is very commonly seen in India. Now, an important differential that is given along with this when you are given this images of pityriasis alba. Now, pityriasis alba is an eczema. So, it will present with multiple lesions, multiple hypopigmented lesions on the face, which will show mild scaling, and on histopathology will show spongiosis. Whereas indeterminate leprosy, there is a single lesion, there is no scaling, no infiltration, no loss of sensation. And if you do a histopathology, you see perineural infiltrate. Yes, it is very endemic to Bihar, Jharkhand kind of an area. Right. Next form of leprosy is determinate form, which is the BT Hansen. BT Hansen is the most common form of determinate Hansen that you see. How does it present? It will present with 10 to 20 lesions which are roughly 10 to 20 centimeter in size. And the typical feature of BT Hansen is this. You see these pseudopodias and you see these satellite lesions. Easy to remember. The leprosy is trying to spread here. From TT it is going to BT, so it is spreading. So, you see pseudopodias, you see satellite lesions, you see approximately 10 to 20 lesions which are 10 to 20 centimeter in size, and here you see hypoesthesia which is not complete, it is not like total anesthesia, but there is significant loss of sensation here, right. So, these are features of BT Hansen. When we talk about BL Hansen, now we are towards the lepromatous fold. So, here you have numerous lesions which will be more ill-defined and would tend to be symmetrical. They are happening on every area of the body. So, tending to be symmetrical, ill-defined numerous lesions with glove and stocking anesthesia is a feature of BL Hansen, and the specific lesions here are called as inverted saucer appearance. So, inverted saucer appearance, glove and stocking anesthesia, numerous ill-defined lesions tending to be symmetrical, we are moving towards BL Hansen, right. BB Hansen is the most unstable form of leprosy. It is in between somewhere tuberculoid and lepromatous pole. So, it is very unstable form, it is a very rare form. What you see here are geographical lesions or map-like configurations are seen. Geographical or map-like configurations are seen. So, you see lesions which are spreading, they are becoming map-like. So, here and there they are going. So, this is a feature of BB Hansen, and you see punched out lesions here. Punched out Swiss cheese lesions are more characteristic of BB than BL. Yes, you are right, whereas inverted saucer is more a feature of BL. So, punched out Swiss cheese are more a feature of BB, though they can be seen in BL also, but if you have to differentiate, they are more a feature of BB, whereas inverted saucer is more a feature of BL. Not exactly 20 lesions, but more than 20 lesions. So, yes, 10 to 20 is for BT, and when you have more than 20 lesions, we are heading towards the lepromatous pole. Right. Okay. So, this is BB Hansen. Before we move on to spectrum, just remember in LL Hansen, you have leonine facies or lion-like facies. What are lion-like or leonine facies? So, lion-like faces is you have rugosities, you have infiltration. So, all the face has deep furrows, wrinkles. So, it looks like a lion-like faces, which is a feature of LL Hansen. Leonine facies can be seen with acromegaly, myxedema and other features also. But if there is associated loss of sensation, think of LL Hansen. Okay. Right. Now, next in leprosy, you should be able to differentiate between two types of reactions, which is my type 1 reaction and type 2 reaction. Type 2 reaction is also called as ENL or erythema nodosum leprosum. Now, type 1 reaction is seen in patients who are in upper spectrum of the pole. So, usually seen in tuberculoid pole. What happens here? You have started ATT on the for the patient. So, usually it happens after starting ATT. The bacteria starts to kill because the body's immune response is good, and so there are a lot of antigens released against which my body mounts a hypersensitivity reaction, which is called as type 4 hypersensitivity reaction. So, seen in upper spectrum, seen after taking ATT, the body mounts a type 4 hypersensitivity reaction. Now, this leads to existing lesions becoming more prominent, more edematous, more red, along with development of nerve abscesses. So, nerve abscesses, existing lesions becoming more prominent are a feature of type 1 leprosy reaction, right. Now, type 2 leprosy reaction on the other hand happens in patients who are in lower spectrum. So, their immune system is already weak. So, this is a type 3 hypersensitivity reaction where the body is mounting antibody, antigen antibody reaction. Antibodies are not protective against leprosy. So, what happens here is that due to some triggers, patient gets pregnant, there is an infection, some immunocompromised state. This leads to further lowering of immune system, leading to type 3 hypersensitivity reaction in lower spectrum patients. So, you see new crops of tender evanescent lesions appearing. Okay, you all want a break? So, I was hoping to finish by 4, but I can give you a 2 minutes break if you want. We'll just finish with leprosy and let's take a 2 minutes break then. Okay, is that okay? And I'll go slow. I'm sorry, I thought we have to cover a lot, and so maybe my speed increased. So, we'll finish leprosy and I'll give you a 2 minutes break, not 5 minutes break, because we have to finish by 4, because I think you have another session by 6. So, you should be fresh for that session, right. So, type 2 reaction is seen in lower spectrum. It is a type 3 hypersensitivity reaction, and usually the triggers are infections and all. So, here you see new crops of lesions appearing. So, how do you differentiate? Type 1 upper spectrum and usually after ATT. Type 2 lower spectrum usually triggers a pregnancy infections. Type 2 is type 3 hypersensitivity, type 1 is type 4 hypersensitivity reaction. Now, the good part is sometimes they just ask you the treatment. Now, treatment for both kind of reactions is MDT or continued with oral steroids. So, oral steroids with MDT is the treatment of choice for both type 1 and type 2 reaction. However, if the patient is steroid unresponsive, uncontrolled diabetic or there is any other contraindication to steroid, then in type 2 reaction, you can also give thalidomide as a second line agent. It is a second line treatment, right. So, first line becomes MDT and oral steroids in both type 1 and type 2, but in type 2 thalidomide is the second choice drug. Clear? Then in leprosy, you should be knowing this, the dosage of the drugs and the drugs because they are very commonly asked. Now, earlier there were two regimens, but now we follow a common regimen. If it is a multibacillary leprosy, we give for 12 months. If it is a paucibacillary leprosy, we give for 6 months. The three drugs that we use is dapsone, rifampicin and clofazimine, which is given in the following doses. So, rifampicin is given monthly 600 milligram, only once a month, right. Half a dose of it, which is clofazimine, is given also 300 milligram monthly. So, 600 and 300 monthly. Now, dapsone is given 100 milligram daily. Half the dose of it, 50 milligram daily is clofazimine. So, 600, 300, 100 and 50. This is the usual dosage for leprosy treatment, right. Okay. Then if it is a child, then you reduce the dose to half of dapsone, 450 milligram of rifampicin, 50 milligram alternate day and 150 milligram. So, you halve the dose except for rifampicin from 600 mg, it becomes 450 mg. Clear? So, these are the dosages of anti-leprosy drugs which are used in MDT. You always give MDT or multi-drug therapy for leprosy. Clear? And these are the strips that are available. These are called as blister packs or strips which are available for leprosy. This is the child pack, this is the adult pack. Okay? Right. So, I will give you a 2 minutes break, have some water and I will resume in 2 minutes, and I think there are few topics which are left. I will try to finish in next 15-20 minutes, right? Meanwhile, put in any questions that you want me to answer. If anybody has any specific doubts, so I can answer for them. Thank you so much. I don't think so it is the cold, I think it's the pollution. So, because this amount of coughing I'm like having since a month, and whenever I'm indoors I'm better. So, thank you so much for your concern. I'll take medicine. Borderline leprosy I've already discussed. So, borderline leprosy is that BT, BL and BB, they are all the different spectrums of borderline leprosy. So, leprosy you divide it into two poles, tuberculoid and lepromatous, and in between is the borderline spectrum. In borderline spectrum we have BT, BL and BB, which I've already discussed, right. The treatment for borderline leprosy you mean, so you do not treat based on the spectrum, you treat based on multibacillary and paucibacillary. Yes, B. Yes, air purifier is my only treatment of choice. You're right. I think that is true for most of the people living in Delhi. I will surely come to wherever you tell me to. You crack your exam and then you give me a treat and I'll come to wherever you tell me to, right? Okay. So, athlete's foot is nothing but Tinea pedis that you see in patients who are joggers or athletes. So they develop this Tinea pedis on the dorsa of the foot or in between their finger web spaces. So, that is called as athlete's foot. Jogger's itch is Tinea cruris, which is seen on the groins. Dhobi itch or jogger's itch is something that you see in the groins, and that's called as Tinea cruris. So, specific video on previous year topics would be this. So, one, for revision we have done this, which is a topic based discussion, and then there was this exam on 50 questions where also I have discussed lot of topics which are important, and their important questions and related topics were discussed, which was conducted in November. So, you can go through that video also. Condyloma acuminata is a anogenital wart. It is caused by HPV. So, there you do not see any moist lesion. What you see is hyperkeratotic papules, whereas condyloma lata is seen with secondary syphilis. There you have moist plaques. So, that is the difference. Lata is like flat, broad based plaques. Acuminata is pointed. So, acuminata is those hyperkeratotic papules that you see with HPV. Okay. Dhobi's itch is same as Tinea cruris. Dhobis, they work in hot humid environment. So, they have this Tinea cruris, which is also called as Dhobi's itch. Condyloma lata is secondary syphilis, don't get confused. Lata is secondary syphilis, condyloma acuminata is HPV. Acuminata means pointed. Right. So, acuminata verrucous lesions in HPV are pointed, hyperkeratotic lesions. So, that is HPV. Lata means broad based. So, broad based moist lesions is lata, which is secondary syphilis. Condyloma acuminata is another name which is given for anogenital wart. So, they can be high risk or low risk both. Buschke-Lowenstein tumor in particular is high risk HPV type. Okay. Lata and acuminata. How can I make it simpler for you? Let me think. So, you have to just remember lata is broad based, right. So, broad based is, if you look at lata, condyloma lata and acuminata, what is broad based? It is the secondary syphilis lesion, right. So, umbilicated lesions for you most commonly you see in molluscum contagiosum. However, umbilicated lesions can also be seen in cryptococcosis and histoplasmosis, in which case the patient will have a systemic manifestation of both of that, and that would be given to you in the exam. Lata is lila. How would that help? Maybe you can say lata has treponema pallidum. So, L for lata, L for pallidum is there in L. So, maybe if that helps you. Okay. So, let us move on, and I think we had a small break, and we will move on from here. So, another image which is commonly asked in the exam, you must be seeing this image for some time. Now, quickly tell me what is this? I'll try to find a mnemonic for you for lata and acuminata. So, we'll move on from here. So, what is this image that you see? Yes, everyone? Oh, very good. So, you have already given me an answer. Yes, these are Fordyce spots. What are Fordyce spots? Fordyce spots are ectopic sebaceous glands. So, these are ectopic sebaceous glands. Sebaceous glands are known to open into the hair follicle, but sometimes they open directly into the skin, and that leads to some modifications that you should be knowing about. So they give you this image. This is Fordyce spots. Now here remember, what is Fox-Fordyce disease? It's different than this. So Fox-Fordyce disease is a disorder of apocrine gland. It is not of sebaceous gland. So apocrine gland seen in prepubertal females, seen on axilla, where they have these skin colored asymptomatic lesions which are present on the axilla. That is called as Fox-Fordyce disease. Don't confuse it with Fordyce spots. So Fordyce spots, S for sebaceous glands, they are modifications of sebaceous glands, right. There are certain other modifications that you should be knowing about. On eyelids you have meibomian glands, prepuce you have Tyson's gland, nipples you have Montgomery tubercles, on lips you have Fordyce spots. Now, this you all know is acne. I am not going to discuss this, just you should know that acne has different gradings and the treatment varies according to that. So, the grade 1 acne is when you just have comedones, grade 2 acne when you have papules and few pustules, grade 3 acne when you have numerous pustules, and grade 4 acne when you have nodulocystic lesions, when you have nodules and cysts. So that is grade 4 acne. Now comedone are the pathognomic or special lesion for acne. Comedone can be open comedones or closed comedones. Now when you have just comedones, you treat the patient with topical retinoids only, right. When you have papules and few pustules, so along with topical retinoids, you use topical antibiotics, right. When you have numerous pustules, so you use both of these, but you also give oral antibiotics to the patient. But if my patient has nodulocystic acne, then my treatment of choice becomes oral retinoids. Apart from all this, you can use benzoyl peroxide in almost all grades. But remember, this is what is commonly asked. In nodulocystic acne, you use oral retinoids. When you are prescribing oral retinoids, remember few things. You have to have 2 negative UPTs. You have to counsel the patient about the side effects. You have to tell the patient about the contraception, and then only you can prescribe topical retinoids. Oral retinoids. Oral retinoids can be given to a patient of childbearing age group. It is not that they are contraindicated, but you have to make sure that you are getting 2 negative UPTs and you are counseling the patient for contraception, right. So this is what you should be knowing. So you are usually given a nodulocystic image and you are asked what is the treatment of choice for this, that is oral retinoids. And specifically what retinoids you use? You use isotretinoin, right. The other retinoids that I know of is acitretin, which is used in psoriasis. So acitretin is used in psoriasis, isotretinoin is used for grade 4 acne. Okay. What is this? It's a compilation of image. So here I have in the oral mucosa, I have oral lacy reticular pattern. On the nails, I can see some pterygium and longitudinal ridging, and on the body okay, Lata has syphilis. You are stuck on this. So okay, so this is a mnemonic. Chat GPT mnemonic is Lata se leta hua acuminatus fellow. Okay, Lata has syphilis, you remember this. I think that's an easier mnemonic to remember, okay. Now, and then, so you have pterygium, longitudinal ridging, and on the body you have 5 P's, purple, polygonal, plain topped papules, which are itchy, pruritic, right. So this is a patient of lichen planus. So this is all the important features that you should be knowing for lichen planus. 5 P's, purple polygonal papules which are pruritic, pterygium in nails which is more specific, longitudinal ridging in nails which is very common. In the oral mucosa, patient has difficulty in eating hot spicy food and you get this oral lacy reticular pattern. So, this is lichen planus, right. Okay, another important images which you should be able to identify. More commonly they give you this is nevus of Ota, this is dermal melanocytic nevi, it is unilateral, it is more common in Japanese population, and you see these speckled hyperpigmented to bluish colored lesions which are present on the ophthalmic and maxillary division of trigeminal nerve, and so it is also called as nevus fuscoceruleus ophthalmiomaxillaris, right. So, you should be able to identify this. ITO is this which is seen on the shoulders and back of patients. How do you treat them? You can only treat it using lasers which are pigment specific. So, use Q-switched Nd:YAG laser, you can use alexandride laser, or you can use ruby laser. Okay. So, nevus of Ota is something which you should be able to differentiate. The next that you should be knowing is nevus depigmentosa. Sometimes and very commonly they give you this image. They give you a single hypopigmented image which is present on the trunk, which is present since childhood, a stable lesion not progressing. This is nevus depigmentosus. You have to differentiate it from congenital vitiligo. Congenital vitiligo will be present since birth and it will usually increase in proportion to body growth. Also, vitiligo is totally depigmented, whereas nevus depigmentosus is actually slightly hypopigmented or less depigmented than vitiligo. So, nevus depigmentosus is also something which is commonly asked. Then you should be knowing about vitiligo. Where have you all gone? There are no inputs, but I think I am going fast now and just telling you everything. So, in case there is anything, you can just put it in the chat box. Vitiligo is another thing that you should be able to identify. Vitiligo is an autoimmune disorder where there is complete loss of pigment. So, you see depigmented asymptomatic lesions which can be present anywhere in the body, and along with that you see this leukotrichia. Okay. So, vitiligo you should know. Good, great. You should be listening and also remembering all of this. So, vitiligo is an autoimmune disorder which presents with these depigmented patches. Depigmented patches with leukotrichia is vitiligo. Here there is something called as segmental vitiligo. Yes, thankfully I have put it. This is also commonly asked. Vitiligo has various types. They can be focal vitiligo, vitiligo vulgaris, vitiligo universalis, but there is a form of vitiligo which is commonly asked, which is called as segmental vitiligo. In segmental vitiligo, you have lesions which are appearing like vitiligo, but they are along a segment. So, this form of vitiligo is considered a very stable form of vitiligo. It has very common association with leukotrichia. You do not see Koebner's phenomena, and this usually does not respond to medical treatment, and the patient usually would need surgical treatment for this. Right? Now, segmental vitiligo, because of appearance of segmental vitiligo, neurogenic hypothesis for vitiligo came into being. So, this supports neurogenic hypothesis. Okay? Got it? So, this is segmental vitiligo and you should be able to differentiate between them. Now, coming to treatment of vitiligo is multifold. You can use topicals, you can use orals, or you can use phototherapy, and in resistant cases you can even go for surgeries. Now, phototherapy usually we do NB, UVB, but we can also go for PUA. Topicals you use steroids and also you use calcineurin inhibitors. Oral, we use oral mini pulse steroids. OMPs are used for vitiligo. Along with that, we use immunosuppressants like azathioprine and all. There is a newer drug which is called as tofacitinib, which is commonly being used for vitiligo. So, tofacitinib is a medicine which is used for autoimmune disorders. It is a new medicine. It is a JAK kinase inhibitor and is used for alopecia areata and vitiligo both. Clear? Right? So, this is briefly about vitiligo. Moving on, lot of times they give you these allergens and you have to identify the allergens. This is nothing but contact allergic dermatitis. So, they can give you various agents which are there. So, contact allergic dermatitis is a type 4 hypersensitivity reaction, we know that, and it is a reaction to some allergen which is there. The most common allergen is a metal, nickel, which is present in metal, and so this is the most common allergen, and here you see allergies happening at the site of ring, keychain, watches, belts, earrings. So, all these artificial jewelries, they contain nickel, and this nickel can trigger contact allergic dermatitis. So, when they are given an image like this, they ask you what the allergen is. So, the allergen here is nickel. Then you can have allergy to hair dye, in which case the allergen is paraphenylenediamine or PPD, or it can be to bindi, in which case the agent is para-tertiary butyl phenol or PTBP. Yes, okay, great. So, you know this. So, this is all contact allergic dermatitis and different allergens which can cause contact allergic dermatitis. Then in eczemas, we have something which is commonly asked, which is atopic dermatitis. Atopic dermatitis is a Th2 mediated disorder where there is increase in IgE and there is atopic triad. What do you mean by atopic triad? That there is a history of either atopic dermatitis, asthma or hay fever in the patient or in the family history. The common manifestations with which atopic dermatitis present is with facial dermatitis in infants. So, infants can have facial dermatitis or extensors involvement. For children, I have flexural dermatitis or lesions are present on flexures, and in adults, I have hand dermatitis. Right? So, these are different manifestations with which my atopic patient can present to me with. Along with this, a very important feature of atopic dermatitis is this, which is an extra fold of skin beneath the eyelid, which is called as Denny-Morgan fold. So, Denny-Morgan fold is another feature of atopic dermatitis. Atopic triad, IgE, flexural dermatitis in infants, face and extensors, and then this criteria. This criteria is called as Hanifin and Rajka criteria. Remember, atopic dermatitis is just a clinical diagnosis. There is no test to diagnose it, and the clinical diagnosis is done based on Hanifin and Rajka criteria. In Hanifin and Rajka criteria, it is very important the patient should be itchy. Pruritus is very important, then typical morphology, chronic relapsing remitting condition, and the personal or family history of atopy, as I already discussed. So, these are some of the major features of Hanifin and Rajka criteria. Then Denny-Morgan fold is also very commonly given. Clear? This I have discussed, so I will move on from here. Then some new genodermatosis which are commonly asked. So, this is an image which is given to you. What is this? This is adenoma sebaceum, usually appears at 3 to 4 years of age. Nasolabial folds, cheeks and chin are common sight, increases during puberty. This is a feature of tuberous sclerosis. Tuberous sclerosis presents with adenoma sebaceum in skin. Now, this is a misnomer. Sebaceum means sebaceous gland, adenoma means growth. No, it is a misnomer. This is actually a cutaneous angiofibroma. It is a cutaneous angiofibroma which we see in children with tuberous sclerosis, usually appears at 3 to 4 years of age and then increases as the puberty hits. Tuberous sclerosis can have other features also like this. What is this? This is ash leaf macules. There can be something like this which is nothing but shagreen patch or collagenoma. So tuberous sclerosis is all about growths, cutaneous angiofibromas, collagenomas, and then this, which are periungual fibromas called as Keenan's tumor. Keenan's tumor or periungual fibromas. So these are different features of tuberous sclerosis. Then the patient obviously has epiloia, which is epilepsy and low intelligence. So epiloia is a feature of tuberous sclerosis. When they are giving you a question of TSC, they may give epilepsy or low intelligence. The patient can have different types of growths or tubers, rhabdomyomas, astrocytomas, and different things which can be present, right? Then they can give you something on Peutz-Jeghers. Peutz-Jeghers, yes, this is also called as Bonville's disease, you are right. Now, Peutz-Jeghers, again, remember this. If they give you something like this, where you have periorificial lentiginosis. So, periorificial lentiginosis along with history of gastric adenomas. Think of Peutz-Jeghers. So, any gastric signs which is given, gastric adenomas being given, think of Peutz-Jeghers, and you are right, STK11 gene is the problematic gene here, right? Okay. What is this? Another very common question with the examiners. You have this castle neck appearance, you have subacute dermatitis in photodistribution. This is pellagra caused by deficiency of niacin, has 3 Ds, diarrhea, dementia and dermatitis. So, there are a lot of questions on this seen in chronic maze eaters. 3 Ds is something that you should be knowing. This is castle necklace sign. So, pellagra presents with photodistributed subacute dermatitis with dementia, diarrhea and dermatitis and eventually death if there is no improvement. Very, very famous and common question with the examiner. They give you this image and they ask you to identify what is it. So, what is it? So, you have an ulcerated plaque with thready margins, with telangiectasias, yes. Please remember this is BCC or basal cell carcinoma. That is what they ask you. BCC or basal cell carcinoma, and this is how it presents. So, you should be able to identify a BCC. What is this? Again, an image to identify. You have a hyperpigmented lesions. Along with that, there is lot of hypertrichosis or increased hair growth. What is it? Seen usually in adolescent age group. This is a very specific feature about it. So, it is seen in adolescent age group. This is Becker's nevus. Becker's nevus presents with this hyperpigmented lesion with lot of hair growth on top of it. It is a rare form of epidermal nevi which presents in adolescent, does not present at birth. Okay. What is this? A 2-year-old child presenting with itchy lesions, urticarial lesions on the body. And when you do this, you stroke a pencil or anything, there is significant erythema that develops. So, this is a patient of urticaria pigmentosa. Urticaria pigmentosa, and this sign is called as Darier's sign. Now, this is not erythema nodosum. This is a 2-year child presenting with itchy urticarial lesions on the body which are persistent, recurrent, and if you do a stroke your pen or anything, there is significant erythema. This is Darier's sign. This is a type of cutaneous mastocytosis. And these lesions heal with pigmentation, and so that is why it is called as urticaria pigmentosa. So, urticarial lesions healing with pigmentation with Darier's sign, it is a type of cutaneous mastocytosis that you see in children. What is this? This is dermographism. So, dermographism is a form of physical urticaria where along the lines of stroking you see urticarial wheals. So, dermographism is a type of physical urticaria. Along the lines of stroking you see wheals. So, it is called dermographism because it is like you are writing on the skin. clear. So you should be able to identify dermographism, and with this I wind up my session. And thank you so much for being very interactive, patient and everything. And I think you guys have read dermatology well. And even if you have not, some of you, if you feel that you have not, I think I have tried to cover most of the important topics in this session and the questions that we discussed earlier, right? In BCC, it's root. Okay. Perfect. So, I'll take leave now. All the very best for your preparations, and we are always here to help you if you need. White dermographism is something that you see in patients with with atopic. So, when you scratch, instead of red, the lesions are white. Okay, so there's blanching effect which is seen. And black dermographism is seen with metals like nickel. So, when you scratch, you get that black line. Okay. Thank you so much for your wishes. In BCC, it's rolled out margins. It's called as rolled, not rolled in, rolled out margins. Okay, great. Thank you so much, everyone. Bye-bye. Take care, rest well and read well.